Hello, everyone. Let me briefly introduce myself. My name is Sergio Tamayo. I am a gynecologist and I am working with fertility issues for 7 years now. Today, we are going to talk about ovarian hyperstimulation syndrome, a serious iatrogenic complication of ovarian stimulation, which is preventable, but if occurs, it can be serious and even lethal. So our goal today will be to make a general review, define what it is, why it occurs, and how we diagnose it. Second, to identify who is at risk, how to prevent the ovarian hyperstimulation syndrome, and if is an existing ovarian hyperstimulation syndrome, we need to know how to treat it. So, as I said at the beginning, it is a complication of the ovarian stimulation that occurs during the luteal phase of the cycle. There is a persistent and prolonged ovarian growth associated with accumulation of the fluid, and particular in the pelvis and in the abdomen. It occurs almost exclusively during the stimulation with hormones and after the administration of trigger with the HCG. However, it can also occur in the course of a spontaneous pregnancy. Why is this important to know about all this condition? It is a frequent condition and in its mild presentation. Like we see, almost 33% of the patients that do a fertility treatment can have an ovarian hyperstimulation syndrome. Thank God it's the moderate and severe forms or the critical forms are not that common. As we see, only 4% are moderate presentation and less than 1% most serious forms. However, this should be zero because it can generate serious complications such as kidney failure, thromboembolic events, and it can even be fatal, like I said at the beginning. That is why our goal should be to have fertility clinic free of ovarian hyperstimulation syndrome, for which we need to become aware and identify the risk factors and know how to act to prevent it first. And if it is the case, treat it in the best way to do it. As we see today, we do many treatments per year, more than 1,000 every year, and in other countries, more than 150,000 cycles every year. So it can be a very frequent condition. Understanding the pathophysiology of this condition can lead to understanding and identifying measures to prevent it, the development, and also to treat associated symptoms. The main component in the hyperstimulation syndrome is vasodilation. I'm sorry about that, which leads to an increase in permeability that facilitates a change in the fluid from the intra to the extravascular compartment, inducing a hypovolemic stage and hyponatremia with hemoconcentration. This entire cascade is secondary to many systemic and local vasoactive mediators that contribute to the pathogenesis of the ovarian hyperstimulation syndrome. However, it is the vascular endothelial growth factor, the VEGF, that appears to have to be the critical for the development of the condition associated with the HCG. This is very important. Is in response to the HCG, like I tell you before, that the VEGF mediates the vascular permeability of the ovary hyperstimulation syndrome. So it is self-limited in non-pregnant patients. That's very important. By recognizing the HCG and VEGF as necessary mediators for this condition, it allows us to establish preventive and treatment measures, as we're gonna see later. The diagnosis is basically clinical in the context, obviously, of an assisted reproduction treatment after the ovarian stimulation. Symptoms generally appear 48 hours after the HCG administration, and they are nausea, vomiting, bloating, and abdominal pain. This can progress rapidly and become severe within 7 to 10 days of the HCG administration, taking into account that this possible progress is very important, and it forces us to do like a logical or very a good follow-up of these patients. The evolution depends on the presence of the pregnancy or not. If there is no pregnancy, the improvement is expected between 48 to 72 hours once started. Although it may last a little longer, and generally disappears entirely with the menstruation. In the physical examination, we find signs such as increased abdominal girth due to ascites, also weight gain, signs of respiratory distress, if there is pleural effusion, signs as dehydration, such as oliguria. In the ultrasound, the most important finding is the increase in the ovary size with multiple luteal bodies and free fluid that suggests ascites. Ovarian hyperstimulation syndrome, like I told you before, is self-limited with a spontaneous regression, although its evolution goes along with the levels of the HCG. So according to the moment of appearance, we have early ovarian hyperstimulation syndrome before 9 days after the HCG administration. It is related to ovarian stimulation and response, and depends on the exogenous HCG that we gave it. In the absence of pregnancy, it's gonna disappear and maybe 10, 14 days after, or that is gonna be again with the menstruation, with the period. The other one is the late ovary hyperstimulation syndrome that occurs from the 10th day on and on after the administration of the HCG. It is related to a pregnancy which prolongs or aggravates and the initial syndrome, and depends on the endogenous HCG, that is the pregnancy. So we don't do always the blood test, but when the patient is already presenting symptoms that do not give us like peace of mind, you know, it is better to do them. We can find obvious depending on its severity. The hematocrit increased more than 45% in severe cases. Leukocytosis more than 15,000. Water and electrolyte disturbance like hyponatremia or hyperkalemia, elevated liver enzymes, decreased creatinine clearance, hypoalbuminemia. That's some tests that it can be wrong. So there are different classification systems regarding the ovarian hyperstimulation syndrome. Depends on the severity of the condition. But we prefer to implement a simple system that allow us to define it and what to do next, the management that we're going to do next after doing the diagnosis. This is one from the Royal College, seems very good, very easy to remember, and it's going to help us to make decisions. So the mild form, where the patient has mild pain, ovary is not so large, we don't really have to give it that much importance, since it occurs a lot in almost all the patients that undergo ovarian stimulation and does not need like a special treatment. Mm, in moderate cases, there's already uh, ascites, but not clinical ascites, only that we see in the ultrasound. And the ovaries are a little bit larger than in the mild scenario. So a patient with already severe ovary hyperstimulation syndrome has clinically visible ascites, decreased urinary output, ovaries much larger than 12 centimeters, and it is how do you call that, like hemoconcentrated, and even with electrolyte alterations such as hyponatremia and hyperkalemia. Once in a critical stage, the parameters worsen even more, and they maybe have respiratory distress or even thromboembolic events. What interests me most about this speech is knowing how to prevent it. And for this, the first thing is that we have to identify who is at risk of presenting the ovary hyperstimulation syndrome and take early measures. So there are several variables, such as being young, a young woman, black race with ovulation disorders, such as PCOS, patients that have already had an episode of ovary hyperstimulation syndrome before, that is known to carry like an increased risk of ovary hyperstimulation syndrome. And others, such as having an elevated AMH rated at 3.4, like is there, or in having an anthrofollicular count more than 24 also is going to give us more risk of having this condition. Estrogen's measurement during treatment, specifically on the day of the trigger, it's also recommended since high levels are related to the ovary hyperstimulation syndrome. Although it is important to know that ovarian stimulation leads to hyperestrogenemia. So estradiol is not the only mediator, since there are patients with high estradiol levels who do not develop ovary hyperstimulation syndrome. So the level of estradiol above which a high risk of ovary hyperstimulation syndrome can be considered is not very clear. It's not very easy to establish. However, if this level of estradiol rise very quickly or rapid, values more than 2,500 or 3,500, and if it's associated with more than 15 follicles, could be a help in making decisions from then and on. Can we prevent them? So we know that in vitro fertilization continues to transform lives around the world today, and the technique has improved from the clinic to the lab, in particular markers to individualize the doses in the stimulation process. The use of GnRH antagonists to prevent the premature storage of LH, the change from using HCG as a trigger for the GnRH agonist, and the possibility of taking it apart, the ovarian stimulation with the embryo transfer in a different moment by freezing or vitrification of the embryos. All this has the possibility of improving the efficiency and, very important, the safety of the IVF. So we have different strategies, and we can define them in primary before it presents, and secondary when we are already on the path to to have the ovary hyperstimulation syndrome. Among the primary ones, we have to reduce the dose, use protocols with antagonists, and other medication that can help. So the first and very important measure is the reduction of the exposure to gonadotropins. So it should be a premise to adjust the dose of the gonadotropins to each patient, and not to apply like standard protocols for all the patients. This especially in patients at risk of developing the ovarian hyperstimulation syndrome. Avoid aggressive doses. Do better the step up protocol, or start late or late onset treatments when the follicles are already between 10 and 12 millimeters. Mild stimulation when going for IVF. All this in patients identified with risk factors of developing of ovary hyperstimulation syndrome. As we see in this study, pregnancy rates do not have difference when the doses is adjusted according to the risk of the patients, especially with the AMH. But the incidence of moderate to severe ovary hyperstimulation syndrome can be significantly reduced. Part of avoiding aggressive doses in the stimulation has been proved by studies like this one, where it showed that the accumulated rate of live births reached like a plateau when there are more than 15 oocytes, but the risk of ovary hyperstimulation syndrome increases substantially after this point. In addition to that, it has also been seen that capturing more than this quantity has not been seen to have like a better quality of the blastocyst. So other studies have shown that pregnancy rates decrease when it is transferring fresh after having captured a large number of oocytes. Bearing this in mind, we can say that it is reasonable not to do a strong stimulation, especially in patients with high risk. What protocol to use? So short antagonist protocol versus long antagonist. There are multiple studies that demonstrate the reduction of ovary hyperstimulation syndrome with the use of the antagonist protocol when compared to the long protocol with agonists to suppress the ovulation. So this study with 7,944 patients in 36 studies in total showed that a 39% decrease in ovary hyperstimulation syndrome when they compare one with each other. The strategy is increasingly accepted. The gestation rates are similar, but with a fewer days of stimulation, lower doses of FSH, lower levels of estradiol, and allows the trigger with agonists when we use the antagonist protocol. So I think this is the one we can use. Concomitant use of other medicine, such as aspirin during the ovarian stimulation. We know that no pharmacological measure will prevent the incidence of the ovary hyperstimulation syndrome by 100%, but this aspirin measure has been shown to help, and recent meta-analysis suggests that can help if you use it during the ovarian stimulation, 100 milligrams. You can use it until the negative pregnancy test, or when you can stop it when you have the evidence of the embryocardia during the ultrasound. Um, so this measure, taking the aspirin, can work as a prophylactic measure of the ovary hyperstimulation syndrome with a significant difference without affecting the pregnancy rates. Another medicine that we can use is the metformin. The exact mechanism by which the risk is reduced is not known, but it is thought that insulin increased the expression of BGF in the vascular smooth muscle cells. So the decrease in serum insulin could reduce the production of BGF and thereby reduce the risk of developing the ovary hyperstimulation syndrome. This review show us that the risk of ovary hyperstimulation syndrome decreased in patients with PCOS who underwent IVF when they used metformin. So far, I can say that, in my opinion, mild ovarian stimulation should be the first measure to minimize the incidence of moderate or severe ovary hyperstimulation syndrome in high responders. However, there are other very important preventive measures, and it is suggested to use as a secondary measures. Of this, it is very important to avoid endogenous or exogenous HCG. This ranges from cycle cancellation, triggering with agonists, and avoiding pregnancy by schedule for transfer in the other cycle. And there are also other measures that it can be used. In secondary measures, it is very important to avoid the HCG. There are alternatives such as triggering with a GnRH agonist. The application of this medicine, this agonist, induced like the release of the FSH and LH sufficient to achieve the maturation of the oocytes. And recent studies not only show a decrease in the ovary hyperstimulation syndrome, but also the complete elimination of the risk of having one. And it was shown that when used in donors, the absence of ovary hyperstimulation syndrome is demonstrated without affecting the results in the patients who received the embryo. So the pregnancy rates are the same and are very good. Not everything is so good, since it was also evidenced that this decrease in the ovary hyperstimulation syndrome it goes together with a little decrease in the pregnancy rates when you do it in like a fresh transfer. So doing or completing the whole cycle when you use own eggs. This suggests that it can compromise the luteal function. But for this, there's also a solution. Other studies have verified that when using the trigger with agonists and given a different luteal phase support with HCG, like given 1,500 units the day of the egg retrieval, showed a pregnancy rate comparable with the group in which the HCG trigger was given. A safe and valid option will be a suspension of the gonadotropins and the no administration of the HCG. So cancel the cycle at the end. But this is the only measure that totally prevents the risk of early ovary hyperstimulation syndrome. The couple should be advised that a natural conception is possible, since natural ovulation can occur afterwards, and therefore a late onset ovary hyperstimulation could occur. So that's very important to tell them. Today, this decision is not usually made, and thanks to the possibility of electively cryopreserving oocytes or embryos, we prefer this measure. In this, we can completely eliminate the risk of the late onset ovary hyperstimulation syndrome, and the couple can get pregnant the month after that. So in the event that it is decided to continue with the cycle and do the embryo transfer despite the already unknown risk of the couple, of the patient, choosing to transfer just a single embryo may reduce the risk of late ovary hyperstimulation syndrome, since the levels of HCG are related to the number of pregnancies, being higher in a multiple pregnancies. Dopamine and its agonists can reverse the increased vascular permeability of the ovary hyperstimulation syndrome by inhibiting the VEGF receptor 2. This recent meta-analysis evaluated the use of dopamine agonists in 7 studies that compared the use of cabergoline versus the use of placebo or no treatment in patients with a high risk of developing ovary hyperstimulation syndrome, and conclude that there is a 62% risk reduction of moderate to severe ovary hyperstimulation syndrome. Also, it has been shown in patients with this protocol that the rates of fertilization, implantation, abortion, or clinical pregnancy are not affected when compared to the control group. So another measure that has shown effectiveness is the use of the calcium gluconate. It is applied on days 1, 2, and 3 after the egg retrieval, and this measure has shown improvement without affecting also the pregnancy rates. This one is very common, and it's very important to say that there are different measures, very common ones, like I said, such as the use of albumin, coastin, and steroids, which until now, the evidence does not support them as effective measures in a significant way in reducing the risk of developing an ovary hyperstimulation syndrome. So let's move on to the next point. Let's say the patient have an existing ovary hyperstimulation syndrome. How do we treat it? So the patient must be fully evaluated from the clinical point of view, vital signs, weight, diuresis, abdominal circumference, etc. And we have to do an ultrasound, see the size of the ovaries and if it has ascites or not. Maybe do a lab test like blood count, renal or hepatic function, coagulation if it's needed, even x-rays. So there's a lot to do. Some symptoms or mild ovary hyperstimulation syndromes are part of the symptoms of normal ovarian stimulation and oocyte pickup. And no specific treatment is necessary and can be managed on an outpatient basis. So without forgetting that the syndrome can progress, so certain measures must be taken. In mild and moderate ovary hyperstimulation, syndrome can be treated on an outpatient basis. But the severe ones or critical ones, it has to be inpatient treatment. In all the patients, even in the mild ones, it's better to restrict physical exercise, mainly due to the risk of the ovarian torsion. But neither have complete rest because due to a possible ammo concentration, there is a risk of thromboembolism. So not do a lot of exercise, but neither complete rest. Hydration is very important. So it can be oral, if it's taken liquids, you can do it like that. If not, you have to do it like in the IV intravenous liquids. If it can drink, normally at least have 1 liter per day. Also, painkillers, antiemetics, checking the vital signs, just to get, like check the patient if it's getting worse or not. Also the weight gain, if we have it. Uh, Check the urine output, also is very important. If it has like loss of appetite, dyspnea, ascites, etc. So if you need it, you can do also a couple of blood tests every 2 or 3 days, like blood count, um, kidney and liver function, and well, it depends on the patient. If you already have an ovary hyperstimulation syndrome, sometimes requires admission to the hospital for treatment. Fortunately, severe cases of ovary hyperstimulation syndrome is very weird, but it is if it is presenting, can have like a fatal outcome. So um, first we have to do the preventive measures, and if the patient have it, we have to do a proper management. So if the patient has like increased pain, or the pain uh, does not decrease with the medicine that is taken at home, if the patient has respiratory distress, or the urinary output is decreasing, also if it has sign of thrombosis, or if it has clinical ascites signs, or dehydration. So in these cases, the goal will be to replace the loss of intravascular volume, restoring the hemodynamic balance. So vital signs monitoring, daily body weight, daily measurements of the abdominal girth, daily water balance. That's very important. And if it needed, give IV liquids. Also, in all patients, do an abdominal or vaginal ultrasound, just to check the ascites and the size of the ovaries. If they need it, also chest X-rays, echocardiography, if they need it also. Uh, every couple of days, blood count, electrolytes, kidney function, hepatic function. Um, Thromboprophylaxis, that's very important, because some patients have risk of having a thromboembolism, and if they have it, they have to be anticoagulated. Sometimes we have to do like the evacuation of this ascites by paracentesis. This is like the measure that best recovers the symptoms of pain, discomfort, also respiratory distress, and even diuresis. In fact, the patient feels a very, very rapid relief from the symptomatology, almost immediately after the procedure. So it should be performed when it has some of this. If there are clinical or symptomatic ascites like pain, even if the patient cannot sleep, it's better to do it. If it has like difficulty to breathe, it's better to do it also. If it has hypoxia, or if it has also hydrothorax. Um, if it has oliguria that not improve with the conventional therapy, this procedure can help improve that one also. Diuresis improves due to an increase in a venous return, because the cardiac output is gonna improve, and also the kidney perfusion. So that's very, very important to take into account. In our center, the easiest way to do it is by vaginal ultrasound, with putting the patient like in Folder's position. It has to be done maybe a couple of times, because the fluid can reappear maybe 3 or 5 days later. So If it happens, we need to repeat the procedure again. So admission to the ICU is very rare, but sometimes if the condition, some of these conditions are present, uh, and admission to the intensive care units is going to be necessary. So the thromboembolism um, is like the most severe complication that involve the majority of the cases with is fatal. And the good thing is that the incidence is very low, just around like 2.5%, something like that, maybe less, and affects the majority of the time the upper part of the body. This is due to the hemo concentration, the immobilization that have because of the pain and the ascites and all that. Also the decrease in the venous return because of the compression. Um, so more than that, also the whole system of coagulation is going to activate. So always we have to use like physical measures like these gradient socks. Obviously, avoid absolute rest, and if the patient has other risk, use always the thromboprophylaxis. Um, and where there is a thromboembolic event or it has a kidney function that is very bad or the respiratory function uh, doesn't improve with the measures that we did before, they should always be admitted to the ICU. Um, Also, this is very important. What we should not do with when we have a patient with ovary hyperstimulation syndrome. Aggressive physical exam of the abdomen, since it generates like a risk of ovarian rupture and even hemorrhage or bleeding inside. Early management with medicine to improve the urinary output. This is not the cause in that moment. The cause is like the lack of intravascular fluids. So it's not the medicine, it's fluids that the patient needs at the beginning. Also surgery, uh, just do it when you're sure the patient or you think the patient has like the ovary torsion or rupture, because otherwise it's better not to do surgery. The patient has a lot of risk of bleeding. These are practical points to take home with us. Always assess the risk factors in patients. Use the minimum effective doses in the wire stimulation process. If you can, in you're doing IBF, it's better to do the antagonist protocol. Also use dopamine agonists like cabergoline because it's going to help us a lot. If you do the antagonist protocol, do the trigger with agonist when you have risk of developing ovary hyperstimulation syndrome. Um, if the patient has a lot of follicles, it's better to do embryo or egg vitrification. Obviously, a good evaluation of the patient, if it's necessary, management with analgesics, hydration, thromboprophylaxis. The main objective of the management with this patient with ovary hyperstimulation syndrome is to avoid thromboembolic phenomena. So that's the worst of the that I fear in this kind of patients. Also, the avoid renal failure and respiratory distress is very important. To sum up, we have enough tools to prevent ovary hyperstimulation syndrome almost entirely. So if the risk still exists, we have tools to reduce the severity of the scenario. So in case of the severe presentation, We must always be there, present with our patients, making a good follow-up and establishing measures that help to return to the basal state as soon as possible. Well, that is all that was I want to tell you about ovarian hyperstimulation syndrome. If you have questions, I will be happy to answer that. Thank you very much.